So, can I, a show of hands, how many people have ever heard of Wondros? Yeah, STSI people don't count, but yeah, right. And a year ago, I would have not had my hand raised, but in our opportunity to work with within the Precision Medicine Initiative, the All of Us research program, one of the many exciting aspects, but one of them is get to know Wondros. And so I want to show a video to give you an introduction to Wondros before I bring up Jesse Dillon.
Really complex ideas are hard to explain. Wondros helps translate ideas for some of the world's leading organizations. Our role is to be a little tiny bit of tissue that connects people to something they might be passionate about. You come to Wondros because you want to develop an idea, to say something about yourself. We have a process that we go through which I think really pulls out the best of an organization. This will actually reveal the underlying question that should be asked. We provide the ability to make visions real. We do the whole thing, from the very first idea on the back of a napkin, to the making of the materials, to the distribution of the idea. We start with this high-level strategy about what we're trying to accomplish, who we're trying to move, and then we'll implement every single piece of content across the entire array of things that they might need. You need to make materials that are bold and striking, like a commercial, and then you need something that really explains the fundamental values and vision of a particular idea. Could be a film, could be a social media campaign. Whatever the expression might be, our role specifically is to help translate the ideas. Wondros is at the edge of storytelling, at the edge of what's possible. It's about imagining a future that doesn't exist. We try and find organizations to work with that reflect the same kinds of ideals that we do. I think that the values are about building a better world and people who believe that things can be good. We see a lot of different kinds of problems, from the very smallest organizations to the very biggest organizations. It's usually a group of people struggling to do something, and we're helping them translate those ideas.
So I want to call up Jesse Dillon. He's the founder and creative director and chief executive officer at Wondros. Welcome.
Thanks for having me.
So you're a producer, and you know, have a lot have directed movies, produced movies and stuff. So what drew you to? I assume that would be more lucrative than working with many of the things we saw there, and especially in healthcare. What drew you to, and bringing Wondros to focus on these areas?
So my son was ill, and he had. He had stomach aches every day, and we couldn't get a diagnosis. And ultimately, we did, but it took a long time. And what I realized in trying to help him was that there were very few storytellers in this realm thinking about the connection between a person who's getting a diagnosis, or a loved one, or a doctor, or a researcher. All these different people, or different groups of people that all need help communicating. And so I started doing it sort of in a small way, and then just it grew and grew and grew over time. So what Wondros is always trying to do is put the person at the center of an overwhelming amount of information, and trying to put kindness at the center of that, to develop a relationship between an institution, an idea, a medical team, and the individual.
So that's taking on a lot, as you've recognized in doing that. So what is, so you, I guess, recognized kind of a lack of storytelling ability or initially, I guess, on the clinical side with the experience with your son. So what did you, as you kind of thought about that and you looked at, what, as you recognize your skills and your experiences are extraordinarily different than what healthcare providers think of or know. So as you thought about, okay, how can we bring this in and help change that, the story or change the ability of people who should be better at telling a story to help make that happen?
Well, I think the thing is to just, again, put the human being at the center of the problem that's trying to get a better outcome. And that's not always just patients, that can also be, there's a great idea at Harvard Medical School, and they're trying to get adoption of the idea, or at the National Institute of Health, they're trying to reach out to people to get them to join. It's like there's always this little piece that gets missed, which is how do you make the invitation? Because all of these things are sort of based on relationships. If you just think about it like if you were going to come in and try and do something with a family, you would go into their house, you'd talk to them about their lives, different things before you started asking them for all their medical statistics. So it's usually just trying to be very thoughtful about that part of the process. And you see that in a clinical trial may be available to help a lot of people, but the researcher and the physicians maybe don't communicate as effectively as they could, which means that you get low enrollment, which means people don't stay in the study. So in order for this science to move forward with people, I think that we need to give more time and attention to those relationships.
So what is it, was there something you put in your team and which is incredibly talented and just fun to work with, put a ton of time into the All of Us program, I'm sure, much more than what the NIH is reimbursing you to do. So what was it about the precision medicine and the All of Us program that drew you to that?
I mean, that's a tremendous project. A project like that is definitely going to succeed, and it'll push better outcomes for everybody on the planet. So being able to take the things that I'd done in a lot of different other places and apply them to that one project where you have all these institutions trying to reach out to underserved populations, to the regular population, to all these different groups of people in this country, to sign up 1 million people. I just thought that would be a very good place for Wondros to work, and it has proven to be a very large project for Wondros because it just has so many different, trying to talk to each health provider around the country that's involved in it, trying to understand their populations, trying to help them to make invitations to talk to other people. That's been a tremendous challenge.
And your team does some unique work to does some unique work to understand the messaging, and so how do you go about doing that? Thanks to better understand how you want to direct the messaging, especially as you mentioned, one of the biggest challenges in the All of Us program is reaching out to individuals who have routinely been underrepresented in clinical research.
So communicating the ideas of biomedical research to people who've never participated in it is a daunting challenge. We started the project when Obama was in power, and now we're doing it with Trump in power, and they have people have very different feelings about the government, both incredibly challenged. And so trying to create that understanding that this will create better outcomes by being able to study everybody, and trying to get people who've never participated in biomedical research to understand that if they're not counted, then they won't be represented in the data is a significant challenge. There's lots of fancy words, ecology modeling, behavioral science, all these different kinds of things, but the real thing that we do is the same thing that I did with all of my other clients, is listening. So it all starts fundamentally with listening. We don't really do focus groups. We do one-on-one discussions with people, and we spend a lot of time with them. We try to go to their houses. We sit with them, try and understand, what their obstacles might be, and then we create maps about where in the system these things can break down, so that clinical trial is a good example. Even though participation is pretty low, retaining them through the whole study is much lower. So the question there is, why do they drop out? What are reasons that they might stay? And so, what we do is we do these very deep interviews, and then we synthesize those reports, and then we build a map of how that works. So we try and be, because obviously we don't do any actual science, we try and do the parts that are around if particle physics has measurement that is totally finite, and then the biosciences are a little more difficult, the social sciences don't even have microscopes, so it's like that's the part we're trying to deal with.
And I always think, you say you do science. I guess maybe the difference is we just don't publish the results.
Yeah.
You implement them, and maybe in healthcare and in health research we need more of that. Implementing and ideally then sharing the learnings after that as we do that. And
well, it's trying to bring the rigor that you would in the biosciences to the study of the behavior around these things, so that ultimately people can get better outcomes.
Yeah.
And that's not just with patients, that's with researchers and doctors and all, hospital administrators. The whole group of people need help because there's obviously a lot of excess, a lot of waste in the system. So how can we be of assistance to help people think about those problems?
Yeah. Well, I think what the All of Us program represents is, as we've talked about, is what we believe the future of healthcare research can go. So All of Us really right now is just a platform being developed to do research in. But one of the things it does is allows any American who's interested, who wants to be able to be involved in research, and we know at least in oncology trials that only about 3% of potentially eligible individuals are involved in clinical trials. So one big challenge to overcome is, okay, how do we allow people, not just in All of Us, but in everything, and we've worked a little bit together on the Exceptional Responder Program and the Stand Up to Cancer and other things, where you really want to cast a very wide net. So you want to get the information outside of just beyond an academic medical center, where if your doctor happens to have time and is involved in the study and feels like the timing's right to talk to you about it, then you may know about the study. But that's a challenge in itself. So you're casting a very wide net, trying to reach a wide population and tell a relatively complicated story, but in a short period of time.
So that's really about understanding the different use cases, breaking people down into sort of personas about how they're going to use it, and then trying to simplify and invite them to participate. A doctor is why are they going to participate in biomedical research? They're busy, they have lots of patients. So, you have to really, you have to make it sort of easily understood for them. And then the user interface to be able to study all this data is a total problem that has to be surmounted, because the simpler it is to understand, the more people are going to participate in it. At Google, they talk about the algorithm, but ultimately it's the fact that I can type in the word chair and up comes a picture of a chair is the most efficient thing for me. So I think that researchers are, we need to make the tools for them much simpler so that they can find the anomalies in the data, because if given the opportunity to, they will. So I think that's, how collectively, not Wondros, but collectively all of us together sort of think about the system that's going to make this possible, because I think that the All of Us research programs desires to have 1 million people, but it'd be better if it had 10 million. And, more millions. And I think that once it gets going, it will, because like I said, I think that whether this project succeeds or some other project, somebody's going to crack this part of it, and it will make better outcomes for everybody in the U.S. and then ultimately in the country. So it's definitely the future of medicine when we talk about being able to go into a doctor, understand our genetic profile, and understand the way others have been treated in the line of our treatment. I think is definitely going to push things forward.
Yeah, and you mentioned, so there's one thing to bring everybody in, and then once you bring everybody in, and let's say it is 10 million, that's going to be close to 10 million different ways where you want to return the results to those individuals, where there are going to be on one end of the spectrum, let's say a quantified selfer who wants to and deserves to have all of their data and everything that they want. And then there's going to be other people, probably best represented by me, that would like to know very little. And I would just like to know actionable things that I can do something about. And I think in healthcare, we've always required talking to a doctor to do that, which I think doctors enjoy doing, but on the other hand, just don't have the time to do that anymore. And I think that part of the communications and being creative about how we individualize that.
I know one of the speakers was saying that we were going to replace doctors. I don't think we're going to be replacing doctors anytime soon. I think that you need a trusted person to guide you through all of this information, even though they only have maybe 7 or 8 minutes at the current time. I think that probably diagnostic tools will get better, but understanding what you're testing and what you're seeing, I think that's still going to be important for the doctor to give us guidance on that. I think the relationship or the role of the doctor can change. I think that was the promise of Watson, was that if you had collectively a lot of doctors put their information in, you might be able to get their knowledge, to help you in the diagnosing a patient. But I think you're always going to have somebody who has to make sense of it, because the individual who's diagnosed is facing an overwhelming set of choices now. We do all the communications for MD Anderson, and one of the greatest challenge, they're a great institution. They spend $1 billion a year on research, but Joe's Crab Shack Cancer Institute on the corner, in terms of an ad, appears exactly the same. So the thing is that the person who's diagnosed, even understanding how to be a good patient, like how to, have their questions laid out before they go in, have a good general practitioner, have a good specialist to understand the test. It's an overwhelming thing for an individual to deal with. So, communications can really help with that. And I think that, sort of giving people tools that allow them to participate in their own care more efficiently is a good thing. So, in terms of, I think that's true. I think there's a lot of people who want to know everything about their research, and there's other people who don't want to know anything, and that has to do with how we do consent. And there's a lot of data sets lying around in the country where consent was not done correctly, and so the data sets are dead. And the samples are there, but we can't actually look at them because they weren't consented correctly. So I think that that's something we struggled a lot with at the Precision Medicine Initiative, and trying to understand how and what ways we're able to use this data in the coming years is important.
And to me, that's one of there are so many exciting things about the All of Us program, but that's one of them. Is it's really, for the first large study I know of, is completely knocking down all the typical silos. So even if the consenting process was done right, it often still sits within one institution, and doesn't go beyond that. Keep talking there. We have about 5 more minutes. If anybody has any questions for Jesse, please feel free to come up, and we'll keep chatting. So, and also I want to point out, just to be fair to Vinod Khosla, he only thought 80% of doctors were getting rid of. Okay. We'd still have 20% of them there. And that is, so everything you said so all doctors, we want to, I think, we always want to do what's best for our patients. There's this sense of being able to share, but we do feel kind of trapped in this inability to communicate. And I think we hear a lot, both researchers and clinicians, we're not very good storytellers. Is there, all of your focus is, or a lot of your focus is often listening to the patients or the healthcare consumers, the participants for the studies. Are there things that we can do that are focused on providers that what Wondros does that can bring to providers to help us be better communicators and tell better stories? Or is it something that can run in the background where you don't have to teach a doctor how to tell a story?
Well, I think the thing about doctors is they have a very difficult job, and you can't expect them to do more work, and make less money. That doesn't make any sense, and nobody's really going to do it. So, I think it's how do we make those things simple for them to communicate? But a diagnosis is complex, and if you're lucky enough that you come in, you get the diagnosis, you get the medication, everything works, it's great. But in general, conditions change over time, people change over time, and it's just about trying to make that relationship between the patient and the doctor more efficient. So there's lots of, technology can be a use for that, texts, there's way to make it more efficient and easier for them to do it. And I think that's the challenge that we all have, which is to make it easier for them to do their jobs more efficiently.
Yeah. And I love what you said at the beginning, and I think in doctors want to do that, in healthcare it's listening, and that we have gotten a system, and you mentioned the 7-minute appointment, where we've kind of lost listening. Actually, there's all these negative feedback to listening. It's like, okay,
Sure.
Quickly, look, don't tell me about the fact that you feel stressed about this, or don't do that. Let me just give you a prescription and move you on, and if we aim for that. Yes, go ahead.
Hi, Jesse. Thank you. My name is Suman. I'm a lung and intensive care specialist. I'm from San Diego, currently working in Texarkana, Texas, where there's a large lung cancer population. We have about 160,000 deaths from lung cancer a year in this country, which is more than breast, prostate, and colon cancer combined. A lot of the reason for that is that there hasn't really been a great movement or great story told in the lung cancer space, as there has been, for example, in breast cancer with the Komen movement and so on. But I think that's changing. Do you have any interest in helping with this lung cancer story?
Yeah, I mean, definitely. I was at University of Pittsburgh yesterday, and I was outside there, a hospital there, and there were 4 people taking their break, and they were all smoking, and they were all people who work in the hospital. So it's, I'm not sure the exact reasons for why, but my understanding is that smoking is a huge part of the lung cancer problem. So, there's entrenched interests there that don't want people to stop smoking. So the question is, how do you communicate in the spaces where you can, in order to help people? How do you help people understand their care? Because they may not be adhering exactly to the protocol. So I think those are all things that have to be unpacked, and the way that we do that is we go there and we talk to 10 to 15 of them, and then sort of distill out what helps them to think about care, and then what, from a behavioral science perspective, could we do that might make them think about it differently. Because with adherence, the things, people change if they want to change. So I think we're always looking for, if we just told them a message like this, they would change. And I don't think that's true. I think it's much harder than that. And I think that there's all sorts of tools that don't get used in how we ask people to do that, from games to, video to, different ways we can motivate people to do that. But I think that, at the core of it, it's being compassionate for them and trying to understand what their behavior is, and then how we can change it.
Yeah, the addiction to cigarettes is likely a disease that's related to the other diseases.
Sure.
I have stage 4 lung cancer patients that still smoke, and they want to quit, but they can't. Part of the story is that we manufacture 1.3 trillion cigarettes in this country every year. We smoke about 350 billion of those domestically, and we send the rest out to other countries like China and India. Yeah. So it's quite a story, and I think it needs to be told.
So that's hard. It's heartbreaking, and the question is, how do you how do we change the behavior fundamentally? Because, we're not going to stop the cigarette company. So it's how do we change people's understanding of that as a problem, which I think, it does change. But every time I see young people smoking, I do find it heartbreaking.
But you look and some of the, I think, when I was a kid and they were just making changes where you couldn't advertise on TV anymore, and now there's some really, I think, clever anti-smoking, which really, one about the pollution with the cigarette butts, so something that just others about how cigarette companies are focusing on people with mental illness and our veterans. Sure. I think is a really interesting change, and as a non-advertiser, I have no idea if those will work. I hope they do. They resonate with me. And then you look, because we're working on potentially for HPV vaccine, where there is, we're maybe at a stage where here we could completely prevent a cancer. And yet there's all this resistance still for various reasons to that. And another area where, we need to move that messaging.
Well, vaccines are, I think that we've done such a good job with vaccines that people don't realize all the things they couldn't get. So that's that they could get. So that becomes sort of a very difficult challenge. We've done a bunch of work on that but again, and the leading place for that is where I come from in Santa Monica, California. It's like, these are educated people that have made a decision not to get vaccinated. And, it's just a ticking time bomb till something really horrible happens, we have to approach them with compassion and try and change their view, over time.
Gail?
Hi, my name's Gail Simon. I work at Scripps, and I'm a project manager for the All of Us research program, working on engagement. And given our political climate currently, I'm just wondering if there's, in the diverse populations that we're trying to reach and recruit and include and retain over time longitudinally, how are we supposed to establish trust given the current times? And if there was one message that you would want to convey to this large group of people, what would it be?
So, we work on that with you. So, the thing is I think that underserved populations have to, I think that it's, we come up with and have made tons and tons of materials. A lot of the materials we've made are from those populations. And I think it's important for us to go and just to be as transparent and honest about what we're doing as we can be. And I'm not sure exactly what the right message is, but I know that underserved populations have not been, in biomedical research. And so it's really important to go and say, well, look, Tuskegee really happened. And that wasn't a figment of anybody's imagination. And we didn't do that. And that this program, if you don't participate, then your great genetic diversity won't be represented in the program. So I think it's about just being totally transparent and honest and asking them to participate. And I'm not sure they'll do it right away. I think we probably have to go there and go back again and spend time building trust in those communities and listening to what their issues are, because they may have very different issues about this than we would think, which is why community organizers are important and artists are important, and sort of building that framework is important, and that's why the work that we're doing here is so important, because I think it'll scale out to all the other areas around the country.
Thanks. And Eric, last question.
So thank you for this great presentation. I deeply care about the value of storytelling within this, particularly for behavior change, as you got it then. Indeed, I'm like reading a book on Save the Cat, which I imagine you would know that well. So my question is this interesting tension that emerges with storytelling and causality. Oftentimes, a story can be very compelling, but not true. Or sometimes the thing that is true is hard to tell a story about. And I'm just curious if you could discuss that tension and how you walk through that, because I feel like all of us is going to have to very carefully grapple with this. I mean, and you brought up, for example, the vaccinations as that issue, right? There's a compelling story there that's not true. How do we handle that in storytelling and narrative?
Well, in the case of vaccines, that's a real fiction, there's some benefit to not being, there's so many different sort of things that have happened there that sort of boggle the mind. So the thing is to try and understand what people's resistance to it is. And in terms of storytelling, no story is true. Once you take two shots and put them together, you've told a fiction. What happens is that you make materials, and the reason they don't last that long is because the story can really only be relevant for the materials that we make. They're relevant for a year, maybe 2 years if you're really lucky, because what happens is the story that you're telling keeps changing, the place that you're going keeps changing. So, with insoluble problems, which are a lot of the things that everybody in this room works on, it's the messages just have to keep changing over time, because we're not going to win the entire war. We're just going to win pieces of it. So the focus has to keep changing, and I think that's about telling an authentic story that's as true as you possibly can make it. I think that the vaccine thing is sort of like, do you believe in the Enlightenment, or do you want to live in the Dark Ages? And the irony of that is that people don't think science has anything to do with what anybody's doing, but they all want to use the phones. They all want the treatments. So I think that we probably have not done a good job of just listening to people and incorporating those into the materials, and then really asking them to come along with us. I do think that ultimately I'm an optimist, so I think that we will we'll beat the vaccine thing. I did a project recently for MD Anderson where I looked at 75 years of cancer research. And if you go back to 75 years ago, treatment was people would get some version of chemotherapy, and then they'd sleep on a park bench, and they'd come back and get more treatment. It's like, if you step back from it for a moment, the rate of success of treating human beings for the conditions that they face has been astounding. So it's, we have all these areas that are emerging: immunotherapy, proton therapy. We have no idea where they're going to take us, but they'll keep taking us to better and better outcomes. So I think what we do is focus on the social science part of it and try and get people ready and more prepared to be able to, take advantage of these things.
Thank you, Eric. And Jesse, thank you so much. I can't tell you how excited we are to be continue working with your team and you for hopefully years and years to come on all of us. But thank you.
Yeah, thank you.